Dr. Benner from Shelbourne Knee Center, and this is the next episode of the Shelbourne Knee Center podcast. And today we're going to talk about an interesting topic in total knee replacement that even over the course of my time in medicine over the last 15 to 20 years, I feel like has gone kind of back and forth into a couple different areas. And that's patellar resurfacing during total knee replacement, what to do with these patients. And, there's I think more of a movement across the pond over in Europe, where most of these patients don't get patella components. And here in the United States, my training was almost always everybody gets one. So an interesting topic that I think over the last several years has gone back and forth. So thank you for joining us, and I hope this will be a good episode. Last week we talked about the donor knee and contralateral grafts for ACL reconstruction. So that's a topic that we're really known for from Shelbourne Knee Center, is doing ACL reconstruction with the patella tendon graft from the other side. So make sure to check out that episode. As always, if you want to check out our podcast, click the like button so you don't miss any, subscribe. And if you have any comments, we'd love to hear from you. If you have positive comments for us, so people that come behind you can see those as well. Scott Bauman's here with us as well, my co-host.
Yeah, Dr. Benner, I'm with you on that. I think this is going to be a great topic and one that's pretty timely. I know there's some good research out there that's looking at the pros and cons of resurfacing a patella at the time of total knee arthroplasty, and that's really one of the big reasons why we're looking into this topic. And I know you have some great thoughts on it, which we'll get to, and we'll also get to a study that we had recently done a couple years ago. Rachel Slavin, a former physical therapist that worked at our office, as well as myself and Dr. Benner, worked on this project, and it was presented as a poster at the Combined Sections meeting for the Physical Therapy Association in San Antonio, Texas in 2022, as well as the American Academy of Orthopedic Surgeons in Chicago a couple years ago. So we will get to that poster here eventually, but to kick things off here, Dr. Benner, just wanted to get your personal experience with patellar resurfacing at the time of total knee arthroplasty, and whether there was a difference with how you approached that earlier on in your training, early in your career, and what it looks like now. So can you just go through some of the personal experience you have with this?
Yeah, so I graduated medical school in 2006 and started residency and was there at Campbell Clinic in Memphis until 2011. So those are kind of my formative years in orthopedics, where I was really spending some time, reading through review materials, studying for the OITE, studying for my rotations as I started doing joint replacement. And at our program, we did total joints as a specific rotation as a second year, fourth year, and fifth year. And then we also did it at a couple of our other hospitals that were more hospital-based rotations, as opposed to mentor rotations. So a lot of joint replacement, as all orthopedic surgery residents go through. And my upbringing at that point was really that everybody gets a patella component. Almost everybody I saw in residency got a patella component, whether they had patellofemoral arthritis or not. So when I came out of residency, it was a foregone conclusion, I think, that everybody was going to get a patella component. And if there was somebody that had, kind of a thinner patella, or, some other factors that maybe somebody didn't get a patella component, it was like, oh my gosh, this is totally different than what we've done on everything else. It felt kind of felt a little different to not put one on. So that was kind of my early experience. And then the same was really the case when I went on to fellowship. I did my fellowship at the Insall Scott Kelly Institute in New York City, worked with Gil Scuderi, Fred Kushner, and Norm Scott, and the rest of that group, Mike King and Will Long as well. Did a lot of total knees in that fellowship. And it was pretty much the same thing, that everybody was resurfacing every patella. But I think they were a little bit more, I don't know if aggressive or conservative is the term, but a little more likely to leave somebody unresurfaced under a couple specific conditions. And those were that if people had a very thin patella, if we measured that somebody was a patella thickness of 20 or less, and if you remove enough bone to get the 9 or 10 millimeter implant in, that you're going to leave about 10 to 12 of millimeters of patella bone left, and they would leave it alone, especially in obese people who we thought were going to put a lot of stress on the patella with squatting activities, things like that, especially osteoporotic females in particular, where we thought there was a little bit higher risk for fracture. They were a little more likely to leave somebody unresurfaced. But I still came out thinking I was going to do a patella component on everybody that I saw when I got it into practice. When I did get into practice, I started working with my partner at the time, Scott Urch, that was doing most of the total knees for for our office, and he had worked with another surgeon at our hospital, Dr. Kevin Scheid from Ortho Indy, and they were doing some unresurfaced patellas. So that was really my first foray into unresurfaced patellas, was working with my former partner. And as you get early out in practice, you're not super busy, and I would spend some time doing cases with him. In that case, I started to see some unresurfaced patellas, and I started to think a little bit more about that. And at that time, started looking into the literature and finding some, kind of formulating my own opinions as opposed to just going with what I was taught. So, those were kind of my formative things. Were originally that it was all patellas, but then having some experience with it with my partner not doing it.
Yeah, it seems like you've been on quite the journey, going from doing mostly patellar resurfacing procedures at the time of total knee arthroplasty and then seeing some unresurfaced. So knowing you have seen both sides of this, what would you say now is really the pros and cons to doing it versus not doing it?
I was awfully nervous about it at first, and it's interesting when you learn a certain way. I don't care whether it's ACL grafts that you do, different techniques that you use for knee replacement, for arthroscopic procedures, whatever. What you do starts what you've been taught initially, and the specific slant that you've been taught based on that experience becomes kind of the way you think it should be done. And then anything after that, you're kind of taken aback by that. So it took a little bit of experience seeing his patients and seeing that they did very well to start to think, you know what, if that patient's got a pretty normal looking patella, maybe I'll just leave it alone. So I started doing some unresurfaced patellas and started to be pretty excited about the results. So then when I went and looked back at the literature, one of the nice things about having a research department is that we can go back and we have staff members who can look things up pretty quickly for us. So Tinker Gray, our research manager at the time, pulled quite a few studies on patellar resurfacing and stuck them in a folder, and I started reading about it. And it seemed like that my impression was there were potential complications either direction, regardless of what you did. And sticking to the pros of an unresurfaced patella, obviously you avoid those potential complications of making the patella too thin. So in particular, we never want to get thinner than 10 millimeters of patella bone, and a lot of people don't want to get any thinner than 12 millimeters of residual patella bone after you make the patellar resection. And at a risk, at any thinner than that, you're at risk of avascular necrosis. And if not avascular necrosis, you could see fractures of the patella. So there are some potential complications with doing the patellar resection. And the other thing is, unfortunately, it's not easy to get it right every time. I've seen a lot of patella cuts that have come in from elsewhere that I look at that patella and resection and thought that patella resection is awfully oblique. And for a while, I thought, gosh, that must stink that everybody else does that. I'm glad I never do that. And then you throw up some of your own X-rays and think, shoot, I miss the mark sometimes also. And you make one a little too thin inferiorly and get a little worried about it, make it an oblique cut, and you hope the patella still tracks normally, things like that. So even things that don't rise to the level of avascular necrosis or fracture, you can still thin out the patella and give yourself a lot of anxiety and worry about it. And it can cause some lower level problems that may not be quite the big complication, but can still make things difficult for patients. So there are definitely some advantages to not doing it. And of course, there's also cost savings as well. We're not paying for patella implants if we don't put a patella component on. So I do think there's some cost savings associated with that.
Now, after hearing that, what would you say would be the downsides to leaving a patella unresurfaced, or the opposite of that? What would the pros be for resurfacing one?
I think the main reason that people don't like to do unresurfaced patellas is there are a percentage of patients who still continue to have anterior knee pain after surgery. And the thought, of course, then is if you didn't resurface the patella and you have anything that causes pain up in the front of the knee, then the patient and the surgeon may regard that as a failure due to an unresurfaced patella. There's always the fear also. A lot of surgeons will say, well, I don't want my patient having a little bit of swelling, a little bit of pain, whatever, just a relatively minor problem, and then going across the street to the other surgeon and have them saying, well, your doctor could have avoided this if they just would have put a patella component on you. So I personally, I don't think that's a very good reason. I don't like to formulate my own opinions based on how someone else might interpret things, what I would consider incorrectly. If somebody goes across the street and somebody else tells the patient that they think I should have done something differently, I don't personally want to change what I'm doing for that reason. But but putting a patella component on everybody does have the potential advantage of not having to have the wonder in your head if somebody has anterior knee pain. Is it because I didn't put a patella component on them? And if I had, would that have been a difference for them? It also takes, there's nobody wants unknowns when you're in surgery, and the patients sometimes get a little hung up on, well, did you, I go in there after surgery and they say, well, did you put a kneecap component on me? Do I still have my kneecap? And if you say, you know what, I thought I was going to be able to do it unresurfaced, but when I got in there, you did have some wear, so we went ahead and put a kneecap component on you. Oh, darn, I was really hoping to avoid that. From my perspective, I don't really think it matters that much, but the patients sometimes almost perceive that as a failure. So, I think there are some definite potential advantages to leaving the patella unresurfaced, and then I think there are some potential negative aspects of not putting a patella component on during a total knee as well.
So you've made a great case for both sides. You talk about the pros and cons of both sides here. So it seems to be that the right answer is finding that right person that needs one, and that may lead to the best outcome. So can you talk a little bit about what your current criteria is for making that decision to resurface a patella?
It's always been an interesting debate to me, because I think if you find that there's no difference between resurfacing or not resurfacing, does that mean you should do it, or does that mean you should not do it? Because I can kind of see it both ways. If you do a study and you find that patients have equal outcomes, no difference in complication rates, some people would interpret that finding as, well, if it's not going to make a difference in outcome, then I'm not going to put a component on anybody. Some people would interpret it as, well, if there's no difference, I don't want that variable to be left out, so I'm going to do it on everybody. And it's interesting if you ask people about this. Surgeons, you ask them the same question, give them the same, if I did a study that showed that there was no difference, what would you do? That you can actually get different answers, which I think is kind of an interesting thing. For me, the difference is, what is the downside? What potential complication am I going to have if I put one on versus don't put one on, and how severe of a complication is that? And some of my feelings of that have been kind of informed by my experience so far. So I've had, I think, the first couple of patients that I took back for a secondary patellar resurfacing, one of them got better, and I felt like I had solved the problem. He'd been having swelling and problems for a while, had been worked up for infection a couple of times, started to have some wear on x-ray, and I resurfaced his patella. He came back a couple weeks later, said, "Doctor, you fixed it. Everything's looking great. I'm so glad we did this." And then he came in 2 weeks later infected. And of course, the question then was, if I'd have done that at the initial surgery, would that have taken care of his problem from the very beginning and avoided an infection on the second procedure? The other one that I did, I resurfaced the patella, and the guy came back and said it didn't really make a big difference for me. And then he went for another opinion on his knee and got an x-ray of his hip by that doctor, and they said, "I think it's coming from your hip." He actually had a total hip, and his knee pain went away. So I resurfaced his patella thinking that was going to help him, and I don't think that it really helped him. So the point is that I think if you do unresurfaced patellas, you're going to have to deal with some percentage of the patients coming back and saying that they're still having a little bit of pain in the front of the knee, and that if that's the case, is the patella resurfacing going to really help them or not? We do have some data to guide us on this. There is some literature support on this that shows us, unfortunately, it's about a coin flip on whether or not secondary patella resurfacing really is going to make the difference for people or not, which of course then begs the question, if half of the people who get a secondary resurfacing don't get an improvement in their symptoms, then was that the problem to begin with? And in my opinion, the answer is no. So we see patients that come for second opinions for knee replacements that aren't doing well. And when they do, if they have pain in the front of the knee, I don't really interpret that as an anterior problem necessarily. A lot of those patients have stiffness, have quad weakness, and other factors that can also lead to anterior knee pain. But the point is that the downside of an unresurfaced patella would be possibly a secondary patella resurfacing. The kind of complications that I've had on the resurfacing side, I've had a couple of patients get avascular necrosis after a resurfaced patella, and while neither of those patients did particularly poorly, it definitely made their quad weakness worse. It gave them some pain up in the front of the knee. Their x-ray looks bad, and there's nothing I can do about it as that patella starts to fragment, and it doesn't have a good doesn't have a good solution. The other one I had a patient who was an elderly female, probably not very good bone stock to begin with, and then I made an oblique cut, kind of thinned it out at the bottom of the patella. This is your patient, if I remember right, Scott. And she ended up having a fracture at the inferior pole of the patella. Luckily, she still had her extensor mechanism intact, but that patella over the course of the next couple of months, despite immobilization, kind of floated up, and up, and she ended up with pretty significant patella alta. But she did still in a little bit of an extensor lag, but she did have an intact extensor mechanism. So for me, the downside of the potential complications with resurfacing, patella fractures that we don't have a good way to handle, avascular necrosis that it's hard to really make better. Those, in my opinion, are worse complications than the occasional person. And in my practice, it's been, I think, 3 or 4 out of a couple thousand total knees that I've had to do a secondary resurfacing on. To me, those extensor mechanism complications, if you do have one of those happen after resurfacing the patella, are a worse problem than if you have to think about whether or not you have to go back and do a secondary resurfacing. So I started to gravitate even early in my career after I saw my partner doing it and having pretty good success, after I started looking at the results of other studies that showed fairly equivalent complication rates, but they were just different complications, that I needed to look at this a little more closely. And in the final analysis, I decided that unless I have a pretty good reason to resurface a patella, meaning full thickness cartilage loss on the back of the patella, I'm usually not doing it. So right now I'm probably, I would say, about 60-65% unresurfaced and maybe 30-35% resurfaced.
Now, knowing those numbers and sticking with the conversation of patient selection, when you're doing your preoperative planning for these patients, I'm curious, how often are you looking at a preoperative x-ray and saying, yes, that's a slam dunk patellar resurfacing versus yes, that's a slam dunk, not a patellar resurfacing, or you're going to make that decision intraoperatively? What's that distribution of those 3 scenarios?
Yeah, so I always sit down with my reps the week before surgery, make a lot of preoperative measurements, discuss any different instrumentation needs we may have, and collect some data, make some measurements and things like that. And as a part of that, we look at a merchant's view, that we an axial view of the patella, that we try to do some patellofemoral resurfacing planning. So if the patient has a normal looking patellofemoral joint, central tracking, although I'll accept maybe a little bit of tilt. If the patient has pretty central tracking, a normal looking patellofemoral space on preoperative imaging, then I usually go into that surgery planning to leave the patella unresurfaced. If I get in surgery at that point, even if we think that we're not going to do it, if I flip the patella over during surgery and I see an area of full thickness wear, then I will change my mind and convert from a planned unresurfaced to doing a patella component. The one caveat to that would be in a varus knee, similar to what guys talk about when they do unicompartmentals on the medial side. In a varus knee, if a patient has a small area of far medial wear on the medial facet of the patella, the thought with those is if you correct somebody out of varus to a more normal alignment, that you're going to unload that medial facet and load it back on the lateral facet. So in that case, if I have a varus knee with a small area on the far medial facet that I'm correcting to neutral, then I will leave that unresurfaced even though they have a small area of full thickness wear. On the flip side, if I see on x-ray that the patient has some patellofemoral wear, they don't have a normal patellofemoral joint on the preoperative imaging, almost never do I go from planning a resurfaced patella to then ending up with an unresurfaced patella. So I may have a percentage of patients, I guess I don't know what that number is, but there are some patients that I plan on not doing it and I end up doing it. It never is that I plan on doing it and then end up not doing it.
All right, so knowing all of that, we do want to get to that poster and that research study that we did together. So first of all, can you tell us a little bit about what the rationale for even doing this in the first place was?
Yeah, of course, the background's what we've been talking about so far, that there are positives and negatives of patellar resurfacing, and in my opinion, a selective resurfacing protocol is the way to go, and that's what I like to do for my own patients. But of course, I don't want to just assume that's the right thing because that's what I think. I like to put it to the test of data. So we wanted to take a look at the existing literature, which showed us that there was some potential advantages, depending on which study you look, for either approach. So our study, the purpose was to evaluate functional outcomes both pre and post surgery between resurfaced patellas and non-resurfaced patellas at the time of total knee, and figure out for ourselves in our own experience what differences we saw.
Now, going into the methods of the study, what were you specifically looking for, and how did you set up that patient population?
So we took pretty much all of my total knees, and divided them into groups, whether or not they had their patellas resurfaced. In the time period of the study, we had 717 patients who underwent a total knee replacement. The good thing about doing a single surgeon experience, you use the same implant, and all the patients use the same techniques. I'm a PS surgeon. I'm a posterior stabilized surgeon, so I took every PCL out and substitute for its function. So there's really the only variable is whether or not they had their patella resurfaced. And of those 717, 363 of them had a resurfaced patella, 354 of them had an unresurfaced patella. There was a little bit of a difference in the distribution of males versus females. The resurfacing group had a slight preponderance more females, 204 versus 159 females. And then in the unresurfaced group, it was 220 males versus 134 females. So definitely a higher percentage of males in the unresurfaced group, a higher percentage of females in the resurfaced group. And then what we looked at is the postoperative rehabilitation between those two groups to see was there any problems with range of motion, both in extension and flexion? Was there a difference in swelling control? And was there any difference in the strength and conditioning program when it came to strength outcomes? So we followed them preoperatively, and then at 1 and 2 weeks after surgery, and then 1, 2, 3, 6, 9, and 12 months. So multiple time periods over the first year. And we measured objectively range of motion and Cybex testing, isokinetic quad strength testing, normalized to body weight, and also single leg press testing normalized to body weight. And then we also used a functional test, the timed up and go test, the tug test. And for those that aren't familiar with that, you start the clock when the patient stands up out of a chair, they walk a short distance to a line and then turn around and come back and sit down. It's just a brief functional test. And then last but not least, we looked at subjective measures, including all 5 subscales of the KOOS.
Now, sticking with the methods, you had mentioned that really the only difference between these two groups was the fact that one had a patella resurface and one did not, including post-op rehab being similar. Now, and I know from this study specifically, and me seeing a lot of these patients, I know that the rehab is the same whether the patients have a resurfaced patella or not. And actually, you get 2 or 3 months out of surgery and you forget what they even had or what group they were in from a treatment standpoint. But I'm just curious to hear, even early on in your training, when you were seeing a lot more of these, were there any specific rehab implications that you would educate the patients on or give a heads up to the therapy staff when a patient had a resurfaced patella versus not, or is it strictly the same rehab across the board?
From a rehab perspective, the short answer is no. There's no difference. We as you know, we don't change any of our exercise recommendations based on the status of the patella. We don't really change anything. The one thing that I do tell the patients about is that they may notice some clicking up in the front of the knee if they have a patella component, which they don't if they don't have one. So you can even tell during clinic sometimes if I forget which one I did, rather than ask the therapist, I just put my fingers on the patella, move it side to side, and see if you can feel the plastic to metal click underneath it. Tells us they had a patella component versus not feeling that. But as far as the rehabilitation goes, we didn't do anything different. And when we started this study, we didn't know if there was an advantage one way or another with our specific protocols. That's really what this study was designed to figure out.
Now let's move into the results of this study. Knowing we looked at those specific parameters and objective measures, what type of results did we find for this?
Well, first, there were some differences preoperatively. The patients who had unresurfaced patellas had statistically significantly better flexion pre-surgery, but it was 123 degrees versus 120 degrees. It wasn't a huge clinical difference. It was only a few degrees, but it was statistically significantly different. And then as we look at a chart over time, 2 months, 3 months, 6 months, 9 months, and out to a year, we do have a chart that was on the poster for that we'll put up on our social media posts about this episode. But the range of motion was really about the same through 2 months, 3 months, and then at the longer time periods, 6, 9, and 12 months after surgery, there was a statistically significant improvement in flexion for the unresurfaced group, but it was about 2 to 3 degrees, about the same difference that they had pre-surgery. So I think while it does appear that across the board the unresurfaced group had better flexion, I think you can probably explain that by the fact that they didn't have pre-existing patella arthritis and that their pre-op their pre-op function was better. On the extension over time, there was no difference pre-op, and there was only one time point, I think at the 3-month time point, where we had like a 0.5 degree or a 1 degree difference in range of motion from an extension perspective. But over time, the curves look pretty much the same, so really no differences in extension over time. When it came to the quad strength, that's where I think it was most interesting. The patients who had unresurfaced patellas did have better quad strength preoperatively, and than the resurfaced group. And then as we looked after surgery, the unresurfaced group seemed to get their strength back quicker when normalized to body weight and quicker side to side. Same thing was true of the leg press. So the unresurfaced group did have a little bit better strength preoperatively, and they were able to get that back quicker postoperatively and to maintain it at a higher level than the resurfaced group postoperatively. So we did see some differences in strength based on the status of the patella. As it related to the KOOS scores, the resurfaced group did have slightly better KOOS scores at a couple time periods at 1, 2, and 6 months, but no differences at the 9 and 12-month period. So while it did look that there was some functional improvements with the unresurfaced group, the resurfaced group had a couple times early on where they got a little bit better symptom improvement, though in the long term it was not better. As far as the tug times went, it did not show a statistically significant difference between groups.
Yeah, I agree with you. I found that the strength results were really one of the most interesting things of this study. I remember looking at the statistics on this and looking at the pre-op and seeing that the non-resurfaced group had better strength preoperatively as well as better flexion. And just knowing that in a vacuum, you would chalk that up to, well, if they're non-resurfaced, that tells me that their patellofemoral joint is probably at a better status level than the resurfaced group, because we know the resurfaced group is going to end up having a resurfaced patella due to some type of patellofemoral damage. So that did make sense. But I know when I looked at just the pre-op values, my thought was that, well, they probably will equal up in the end, because post-operatively, you could argue that both have a better or more normal patellofemoral joint, and they really didn't. As you notice, the unresurfaced group tended to have higher strength levels throughout every time point post-operatively. So I did find that interesting. Is that something you were expecting as well, or what were your thoughts on that?
I don't know that I really necessarily expected that preoperatively, but the after we see the results of this data, and I kind of tried to wrap my head around that, I came to a lot of the same conclusions. I think that the patients who needed patella resurfacing at the time of surgery obviously had a worse looking, more arthritic patella than the people who were unresurfaced. So I think that explains why the resurfaced group, especially in the early time points, had a little bit better symptom relief, a little bit better functional and subjective scores, because their knees were worse to begin with because they had an arthritic patella, and the other they had a worse problem than the people who had an unresurfaced patella. But I think that the unresurfaced group had better strength pre and post surgery, and I think the reason is that it does seem like there is an advantage to the patients having their own patella, and that does seem to give them better strength early and late. So I think you can see by this study the kind of pluses and minuses of each. For me, it still kind of points to unresurfaced patellas, though, because those patients aren't subject to their symptoms being as bad, so they still get the same kind of outcome, and those functional gains that they have because their patella is pretty normal, they get to keep and maintain throughout the post-surgical process. So, and then of course there's the cost savings associated with not using patella components for the entirety of the healthcare system, and I think that's important as well.
So before we wrap up here, I'm just curious to hear your thoughts on what your take-home clinical message is with this study. Knowing that the flexion is a little bit better, the strength is a little bit better for the unresurfaced, what would you say would be the clinical take-home here?
Well, I think that those functional differences I do think are pretty significant, and I think that's something I really learned from going through this study process, was that those patients who have patellofemoral arthritis versus those who don't are going to have a little bit worse function pre-surgery, and that they may get a little bit more of an improvement post-surgery in their symptoms because, like I said, because they have a worse problem. But I do think this study highlights that leaving the patella unresurfaced does make the patient's function a little bit better pre-surgery, and it does maintain it at a little bit higher level post-surgery. And I think that's important. The other one that I didn't really talk about, I guess, in the results was we didn't really see much in the way of complications in either group. We didn't see any patients patients have fractures or avascular necrosis in the resurface group. We saw nobody in the unresurfaced group that came back to have a secondary resurfacing. So I think one of the real potential problems is if you're going to say, you know what, I'm changing my mind today and I'm going to stop putting patella components on people, and then you have people starting to come back for reoperations because of it. I think that's a potential problem, but we did not see the chances of having problems with the patellofemoral joint were really not existent in either group, which is of course a positive thing. And the last take-home point, I think, is just that you have to really think critically, review studies, and review your own data and your own experience before you come up with what you want to do on these. I guess I was really a little more dogmatic early in my career that I learned that we do a patella component on everybody. I learned there's some potential problems with unresurfaced patella, so that's what I'm going to do. And it was really eye-opening for me to work with somebody who didn't, and to be open to that, to a difference in that protocol. And then after reviewing the literature and thinking about it, about the more nuanced portions of this, how that kind of changed my thoughts on it. And then even more so once we did the study, utilizing our own data to be able to look it up and come up with our own thoughts based on what our patients tell us is really important to everything. But I think specifically for patellar resurfacing, it's a lot more nuanced than I think people really give it initially. Specifically, like I said, it's bothersome for me when people say, well, I just do it because I don't want them going next door and having somebody say that I did it wrong and end up with revision surgery. Find out what you think about things based on the literature, track your own outcomes, evaluate and appreciate all the nuance to this debate, and come to your own conclusion for what's best for you and your patients.
Excellent. Well, I appreciate you going over this. I think you bring a pretty unique and interesting perspective on this, as you really have gone through the, both ends of the spectrum, as you started off with doing a lot of resurfacing and then transitioning to not a lot, and then settling in somewhere, I think in the middle. As you said, it's about 60% now, and then able to get to that conclusion based on some of these studies as well as your own anecdotal data. So I appreciate you going over that and giving us your thoughts on this.
Well, thanks everyone for joining us at the end of today's episode. If you'd like to contact us or follow us, you can find us on Twitter and Instagram at the SKC Podcast. We have a YouTube and Facebook page for the SKC Podcast as well, or you can email us, the skcpodcast@gmail.com. Come back next week for our next episode, and we'll talk to you then.